And now I would like to introduce Paul Winston, but I think I don't have to do it. And I saw that it was really, really important that to give, the microphone to Paul, because as everyone knows here, there is, a real huge commitment for the development of neuroorthopedics during this very complicated period by the Canadian team, and I think it's very, very important to make a summary of what they have done. And I know that every one of you have participated to whole this organization, except me. I'm so sorry for that, Paul, but I'm going to do it, sure, one day. And after that, I wanted to show you what we have done in our department, and mainly the Normandy team with Lorgata and Marjorie Salga, just to show you how we have, continue our pathway. So.
Merci bien. Merci bien. C'est un grand plaisir de vous présenter aujourd'hui. Thanks everyone for letting me speak today. We've been very busy in Canada trying to be like the French and Italian teams. So my colleagues would like to say hello that could not come. We established CANOSC a few years ago, Canadian Advances in Neuro-Orthopedics for Spasticity Congress. It's as difficult to say, but we have decided we were supposed to have in-person meetings. The last one was canceled, but we have become an online webinar for neuroorthopedics. And we are getting about 50 countries registering for every lecture. Everything is free, thanks to sponsorship, and many of the French team and Italians have presented. So we are now reaching out all over Africa, South America, Asia, and many teams presenting. This is our board of directors for many people that you know. We've been deciding to publish, so since the last time we were here, we've had many publications, and we've partnered with a lot of the team in this room as well. So we've been really trying to advance our academic contributions. When we were here 2 years ago, Francois, you said we have to plan for the next 100 years. So I emailed the head of my hospital and said, it's just me. I have nobody. I don't have a physiotherapist, an occupational therapist, a research. I can't do anything without help. So I've been finding help. But I decided to move France into the future. So we just got our first Pâtisserie Paul in Vancouver. But I decided to make it a little bit more modern on a snowmobile and with a bit of ice, because in Canada it is a cold country. But I always prefer Thierry. So the best patisserie in Vancouver is Thierry, which is very appropriate because everyone in neuroorthopedics from Belgium is named Thierry. So this is where I still go. I now have an équipe de spasticité. This is my research team. I have a physiotherapist, kinesiologist. Dr. Eve Boissonneau is my fellow here, and we have different people. And we are very dramatic. So this is 20 minutes from my hospital, and we do our research meetings hiking or randonnée. So I'm going to explain how we've really completely changed our cryoneurolysis program since I was here last time, and it's become quite advanced. We published our first paper in 2019 showing how to do cryoneurolysis. The biggest change was in Canada, this device came on the market. It is a handheld device. It will be available in France, Italy, all over Europe very soon. And it is a single-use cryoneurolysis machine that you can use in your office or in the ambulance of Lorgata. And this is Dr. Boissonneau demonstrating how we do cryoneurolysis. So a percutaneous cryoneurolysis with a single-use probe. This is how we stimulate a la Deltome, the same technique. And this is how we generate an ice ball. So at minus 88 degrees, we generate a ball of ice. It comes on in about 5 seconds, and our cycles last 104 seconds. We do everything under echo, and tomorrow I will be talking about ultrasound. So you find your tibial nerve, you put in your probe, you generate a ball of ice, and you freeze a nerve. What is quite amazing about cryoneurolysis over the last 50 years of research is cryoneurolysis causes a complete Wallerian degeneration or second-degree axonotmesis. So you get rid of the entire Wallerian conduction of the nerve, but the epineurium and perineum stay. So this is not phenol. The nerve is perfect. So it's like putting a chicken breast in cuisse de poulet cru, in the freezer. You can freeze it and take it out 6 months and eat it. If you put it in the microwave for 30 minutes, it will be dead and you cannot eat it. So nerves will regenerate after 3 to 6 months, and they will begin to conduct electricity again. So we presented this first case with François Genet in Paris a few years ago. When we decided to do motor nerves, we thought it was crazy, but actually it had been published in one obturator and one rat study. And this was the first time we ever used the Tardieu scale, thanks to Thierry. And this was a complete example. So 16 months after stroke, classic, fast catch, and V1 was maximum. Now, in France, you use the term a musculotendinous contraction and a fully reducible deformity. I have to teach that to everyone because only the French say that, and it is the perfect word. Unfortunately, we found out most of these contractures don't exist. So we thought all these patients have contractures, but in many of them, they actually have fully reducible deformity. They just have too much spasticity. So this gentleman is demonstrating how 9 days after, or 2 weeks after, he's actually getting some neuroplasticity, beginning to use his arm. The difference with toxin is it doesn't go away. It gets better with time. So at 3.5 months, he has less clonus. He's using his arm. And the nerve is reinnervating, so his power will come back. This was just brachialis branch with a Genet method. And what's nice is he can now mow the lawn, lift up his grandchildren. He had very little power because he couldn't lift his hand before. Now, 1 year out, he is still doing quite well. Now, people always say, won't you make them weak if you take out the nerve? But we actually make them stronger because they can begin to use their other muscles for flexion and they can strengthen their extensors. So he is 2 years out from the procedure and he is showing me that he is actually quite strong and he can create his strength. So when we started with the musculocutaneous, we do 2 to 3 lesions at minus 88 degrees. So this is Dr. Boissonneau showing. And tomorrow I'm going to talk about echography, but you have always the neurovascular bundle and the nerve comes off. So it's actually much easier. We can do a nerve block in about 10 seconds because you find the blood vessel and you see the nerve and stimulate. So these are 2 lesions to the brachialis. This would be a classic Genet nerve block that we would do on a patient. So a lot of spasticity, but we can get her to relax quite easily. And the great thing about cryoneurolysis is you get an immediate effect. So you get an immediate block from the freezing. So if we just do brachialis and there's still tone, we will add in a radial brachioradialis, or we will add in a biceps. So we know what we're doing. It's like a live surgery. And you can see her 6 weeks later, there's still a little bit of tightness in the brachioradialis. So we will either do toxin or we will do another cryoneurolysis. And you can see with a block on the left, she's much looser, so she needs her brachioradialis. At the beginning, we were just doing the elbow. And this woman, we do both now brachialis and brachioradialis at the same time. And we did publish this. This is an open access journal. You can watch how we do this technique on 11 patients. And this would be a case, we are doing a lot of cerebral palsy patients now. So this is how you do a echo to the biceps. You can see you would normally offer a percutaneous or surgical lengthening for his biceps, but the mother did not want that. And just 1 month after, you can see the allongement, the biceps is much longer, and it doesn't look so retracted. And what we find amazing is in these people with cerebral palsy, who've always been this way, we can get a lot more lengthening. So you can see 2 months after, he still has some contracture in the elbow, but that's enough. But you can see it's not pulled. And as he grows back his nerve, he will be stronger and the spasticity will not come back. And this is how we do this is the nerve block for his biceps to test. Just coming off the blood vessel, you can see the lidocaine going in. This is how we do a tibial nerve cryoneurolysis. This is to the whole trunk. Most of our patients, we started doing selective, but most of them benefit from the whole trunk if they have cloteau la griffe, and it works quite nicely. So we do a lot of tibial nerves now. This was one of our first patients, so she was pregnant, so she could not take her toxin. She could not wear her orthosis because of pregnancy swelling, and 5 minutes later, she has a step-through gait, so she's quite happy. Her gait is improving, and then we can offer her a month later. She is now 8 months pregnant. She still has some weakness, and I recently sent her for surgery for a splat procedure, But you can see 10 months later, she was walking very nice. In fact, she was too good for her orthosis. So this is the typical cryoneurolysis that we see, very quick change. And what's nice, as I said, is you know immediately the effect. This is a more typical patient that I will see. So he had toxin for 10 years and 5 minutes later. And what we find the most with the tibial cryoneurolysis is the effect on the stiff knee gait. Getting rid of the gastroc really relaxes the knee, and they're learning to get tibial progression and stepping through. So this was, he sent me this video during our lockdown in early 2020, and he is learning to walk. He had no physiotherapy. But he comes back now with physio, and he is learning to accept that he can walk on his hemiplegic leg. So he's getting much better. And so he is now 2 years after the procedure, and he's maintaining his range of motion. His nerve has grown back, and we were doing a study with H reflex, and we're finding the nerve does regenerate to the way that Thierry Deltome did H reflex with neurectomy. This is another patient where he cannot even walk without his ankle foot orthosis, but just about a month later, he's able to walk with physiotherapy supervision only. Again, not a perfect foot for a foot surgeon, but many of these patients will not go for surgery, so they are happy enough. We can be very specific. So this is the flexor digitorum longus branch of the tibial nerve. And this would be a classic griffe gait that you have, which is a spastic dystonia, as Thierry Deltome will tell you. And when he reinnervates, he will probably get it back because it's not spasticity. But you can see how nicely after cryoneurolysis, he doesn't have griffe anymore, so he's quite pleased. We just saw him 2.5 years later, and it's starting to come back, but it takes us 10 minutes to do the procedure again, so we will fix his toes. This is how we do the cryoneurolysis. This was for our original unit that we used. In this case, he has multiple sclerosis, so we only want to do the gastrocnemius. We do not want to do the soleus. And this is how we do the procedure. And this is the example. So when I bend the knee, he does not have any resistance in varus. But with the straight knee, you can see he has tone in his gastrocnemius. So we only are going to gastrocnemius, but 5 minutes later, the tone is gone. And he is going to be able to walk. Now he's weak because he has multiple sclerosis, so we will have to train his strength. But 1 month later, the foot is very loose, so he is able to clear his foot when he walks. This is me, my pectoralis major. And you can see it's my favorite block because the lateral pectoral nerve is 100% consistent in all cadaveric and human studies. So the blood vessels are inside the lateral pectoral nerve. It lives below the pec major. We are doing lots of pec minor as well, but the pec minor is harder to find because it divides into 4 branches. All that literature comes from the breast surgery reconstruction literature, and it's very good. So here's Dr. Boissonneau doing a lateral pectoral nerve cryoneurolysis, and you can see just to the left of the ice ball, you can see the blood vessel. So we stay away from blood vessels. This was our very first pectoral nerve. It is an incomplete quadriplegia on maximum dose botulinum toxin, maximum dose baclofen, and a sip and puff wheelchair control. So he is stiff on both sides, a lot of spasticity and clonus, and 9 days later. And this is maintained at 3 years for him. So this is our typical finding for PEC. What it does is it really frees up the amount of botulinum toxin so we can move it to other areas. So this would be a classic patient. Remember, he's quadriplegic, so you have to be careful with toxin. He can't open his fingers, so we do an ulnar nerve block at Guillen's canal, and then we do toxin to just the interossei, and then he's able to open his fingers better. So this is what we are doing. We are taking away the need for toxin and putting it in small muscles. Originally, we were too afraid to do median and ulnar nerve, but we changed that. So this is him learning to reuse his hand. And he was able to change to controlling his wheelchair with his hand. This is our classic case where we thought this was a muscular tendinous contracture, and we're finding this in patient after patient. This is a stiff, painful hemiplegic arm. 10 years, she cannot abduct over 90 degrees, but with a simple nerve block, we can increase overhead. With cryoneurolysis, 1 month later, she has very good range of motion. We have begun to add in suprascapular nerve cryoneurolysis, which I'll talk about later, which makes all the difference. But it is maintained, so she is well over a year now, and the spasticity has not returned in her shoulder. The patients who don't have active movement, it's a big, big change for caregiving. Those who have active change, it's very important. This is one of my patients that I've been treating for many years. He's had cryoneurolysis everywhere now after 10 years of toxin. And you can see on the left, when I ask him to raise your arm without gravity, he's going to reach with his hand to pick it up because he never lifts his arm on his own. But right after cryoneurolysis, he said, "Oh, this is so easy." But 1 month later and 3 months later, he is now gaining anti-gravity strength. And he's actually laughing, don't worry, because I'm moving so fast. And what's great is his hand, he was in a clenched fist. We also did median nerve. This is a more severe case. So she's 7 years post brain aneurysm, extremely fibrotic. So Rajiv Ribai is working with Alessandro Pacelli in Italy and Munin in Pittsburgh on the HECMAT score, which is fibrosis after stroke or spasticity. And you can see I cannot resist her. The wrist is fused. She needs a surgical lengthening of the wrist. She does not want to, but very tight in the shoulder external rotators, and her elbow cannot extend. But 1 month later, after cryo, she's gaining new range of motion, so she's going to demonstrate how much looser she is. And I can now take her arm right over her head. So that was V3. V1 is right over her head. And then I can also extend the elbow. So that was after her nerve block on the left. So I know that my cryoneurolysis will do whatever the nerve block did and much better because you were going to stretch in therapy. And you can see here that her elbow is now opening. Her muscles are so fibrotic that when I straightened her elbow, you actually heard tearing. And we're going to put her in a serial cast for 1 month. We are checking all of our outcomes in the upper extremity in a study looking at the Tardieu scale, the active range of motion, the modified Ashworth, and we do a grip strength, box and block test, and we are doing a disability arm, shoulder, hand. What I find most exciting is we are now treating patients that have been this way their whole life. So this is a nonverbal patient that we decided to do cryo on because his mother found he was crying out in pain, going to the bath, getting changed. So Dr. Vincent, who developed all these protocols, he has retired, so I'm doing all the cryoneurolysis with Dr. Boissonneau now, but you can see that we cannot abduct overhead. External rotation is quite good. So this would be a bilateral deformity. But 1 month later, he is going overhead. Now, his whole life, he has never abducted over his head. So we are finding that many of these patients are not as contracted as we thought they were. And very nice. Now, I did not see him for about 9 months because of COVID, and he had no therapy, but he's much better at 8 or 9 months. So just his mother and caregivers are working with him. He would go to the hospital every 2 months for aspiration, and his mother said his breathing has been much better since he's calmer and not in pain, or maybe because they have not gone outside to see anybody. So the most interesting is we were very afraid to do median nerve because median nerve is a mixed nerve, so you will take out the sensation. But this patient was adamant he wanted his hand to open because it smelled so bad. And what we have discovered when you do nerve blocks on median and ulnar nerves after stroke, they have no feeling, so they do not mind. So if we do a nerve block and there's no sensory disturbance. So he is showing here, he said, my hand smelled like a dead fish. He was so embarrassed, he could never clean it. And he is going to explain why his hand is so much better after median nerve. And he's actually 3 years ago, so he's actually got a little bit of motor, but we did below the elbow. And Dr. Boissonneau and I just repeated it above the elbow because we want to take out pronator teres and flexor carpi radialis. I will show you tomorrow, but we can do the median nerve right next to the blood vessel. We are doing a lesion just below the median nerve here. This would be an example of a contracture. This patient needs surgery. I cannot fix his wrist. His fingers are so painful. If I touch them, he says, please stop, please stop. So significant pain. So we do cryoneurolysis above the elbow, and his fingers immediately will release, but no contracture at the elbow. So what we thought was a contracture, at the wrist is loose, and he has an immediate effect. So this is only 5 end of the procedure. And that is not a contracture. That is just too much spasticity. And the great thing about cryoneurolysis, if we don't get the effect we want, we can immediately do an ulnar nerve as well. So this is him 1 month after. And again, his muscles are fibrotic. I need to stretch. Need to stretch? Is that better? Okay, thank you. So this is a patient that has myasthenia gravis and fasciculoscapular humeral dystrophy. Okay. And he cannot get toxin because of neuromuscular junction disease. He was referred from his care home because he was crying every time they touched his hand. His hand was in so much pain and he was getting infection. We did suprascapular nerve for pain, pectoral nerve, we did biceps and brachialis. We also did median nerve. So his hand is completely open, and you can see his skin is very red where the skin was breaking down. But he is now demonstrating power. He had a stroke after myasthenia. So now his fingers rest open. So the first time his care team has ever been able to touch him. But we are now doing this. We do the whole arm in one sitting. So one treatment of 1 hour, we can do all of these nerves and sometimes the leg. Now, because we took out the median nerve, my physiotherapist is saying you actually can use your hand now because you have a radial nerve. So we knew that he is not paralyzed completely. So he is beginning to open his hand, learning, and you can see how long his fingernails are. So his fingernails have not been cut in a very long time, and they were cutting into his skin, and we are teaching him some motor planning. Some of them will get a grip strength of maybe 1 kilo, 3 kilos, but that was the reason for referral, so skin maceration. So now we can cut his nails. Because it's a median nerve block, he doesn't have median nerve pain. And we are doing many, many hands now. So this was a patient that we just did, and he was referred because his hand was in a fist. He said toxin did not work, and his main complaint was shoulder pain. So we are showing that he's very stiff in his shoulder. He has a muscular tendinous contracture, you would think. So there's his pectoralis tendon, so very stiff. This is fast forward. So we cannot lift him overhead. We cannot open his hand. Suprascapular for the pain, and then we did a medial and lateral pectoral, no tendon. Very easy. This is 5 minutes after the procedure. We did not expect his hand went loose. So when we got rid of the pain, his hand started hanging loose, but his wrist is still quite stiff. So we go back, we said, can you open your hand? He said, I've never opened my hand on my own, so now he can do that. We did nothing to the hand. This is just the shoulder. So 10 minutes later, the pec tendon is very loose, so it's working. And I'm not happy because we can't extend the wrist. So we decided to do a median nerve above the elbow. So we are going to do a median nerve above the elbow. His fingers are nice and loose now. And I can go all the way back in extension, and there's no tenodesis. This will get better every day for 3 or 4 months as the nerve breaks down and we stretch him. So we are now doing one muscle after another until we are finished. And if we are not happy at 3 months, we add in more muscles as well. The obturator is something that I was really lucky to see the surgeries in Lille with Professor Fontaine. And it can be a very difficult, deep nerve to access. It's very easy with cryo. So this is an obturator, and I'm going to show you tomorrow how we localize that. So this is a patient with hereditary spastic paraparesis. He already had neurectomy and tendon lengthening on his gastrocnemius, but he wanted his obturator because he works in heavy construction, and he's already able to walk with his legs open, so he's very happy. And this would be a typical patient. So she likes to horseback ride, and she cannot, and she could only walk maybe 100 meters. We did her and we are teaching them to walk an abducted gait as well. So our abductors are going very well. We can also do the femoral nerve. So the femoral nerve is very easy to find because the nerve always lives off the blood vessel. And we did our first femoral nerve, Dr. Boissonneau did recently, in an MS patient. And she just got up and started walking without a stiff knee gait. She was really, really excited. We cry a lot in our clinic because it's very emotional. And this patient, she's laughing because I cry all the time. So she's had cryoneurolysis in many parts of her body, and we decided to do the hand. And for her, what happened, she was just standing there and her hand kind of opened. And she was just looking, and then her husband went over and grabbed her by the hand and walked around the room, and everybody started to cry because they've never walked like a couple before in the 15 years. But I still wasn't happy because her hand was still closing, so we did an ulnar nerve, and then that really took out her interossei, so her hand can hang loose now very nicely. So we study on the upper extremity, which is surgery and neuroablative procedures. And last time I was here, my colleague Dr. Kraus was here, the plastic surgeon, and she got a little bit mad at me because she said there's nothing left for me to do with neurectomy. So we are doing our neurectomies first, and then orthopedic surgery comes after, and then we are doing all the corrective surgery after, because we want to see how much reduction in spasticity we can get before. We have an H-reflex study in the lower extremity, thanks to Thierry Deltom's excellent idea, and we are watching how long it takes for the H-reflex to go away. And we have an operator study going as well. So that's what's happening in Canada. Thank you. Can I start the next one? Je peux le lancer?